In the PCR, it's going to ask us a couple of different ways, and at different times we have to be able to document the mental status of the patient. So to quickly review this, any patient that's alert means you walk into the patient's room and they are aware of their surroundings. They are aware of their environment. And for a blind patient, they can still be alert, even though they can't physically see you, even if they hear you, but they know what's going on. They're fully aware of their environment, even though they can't physically open their eyes. They would still be considered eye spontaneous because of the fact that they are fully aware of their surroundings, as many blind patients are going to be considered alert. With that in mind, if they are sleeping at 3 o'clock in the morning, you wake them up to be able to do an assessment of the patient. If they're sleeping, but they're easily arousable, and once you arouse them, they are awake, they're alert, they're talking to you, they're coherent, they would be considered alert. If they are not able to be aroused at all until you really need to be able to yell, shout because of a diminished mental status, that would be a different story. But keep in mind that patients that are sleeping at night, if they need to be woken up because they are simply sleeping, that may not classify as a diminished mental status. Now, once we use the term alert, we typically use that ANO times 0, times 1, times 2, or times 3. And we're going to ask the patient 3 or 4 questions. We're going to ask them, what is your name? Do you know where you are right now? And can you tell me the day of the week? Day of the week might be good, but not every patient would know that all the time, right? For example, a patient in a nursing home, somebody doesn't come into their room every morning and say, hi, good morning, it's Wednesday, right? They may not know what day of the week is, and that might be normal for them. So we might have to delve a little bit deeper because I don't expect that patient to know the day of the week at all times. So maybe what month it is, what year is it, what season it is. And that might be appropriate for them to be able to tell you a little bit more information that they understand the concept of passing of time. And that's really what we're looking for. Maybe some people use what precedent it is, but then you're getting a little bit political maybe. So if they only answer 1, so they know person but not place or time, it's ANO times 1 to name. And again, if I'm going to use that 1, I want to be able to document which one was it, which answer did they know. If they document ANO times 2, I'm going to document name and place. 4 times 3, I kind of have the understanding of I know which ones that they were able to get all the answers. You may see the term ANO times 4. ANO times 4 is indicating understanding and decisional capacity. It's not a requirement to use the term ANO times 4. You may see it. It's a little bit higher level of understanding when we document ANO times 4, meaning patient is fully with it. And it might be helpful to be able to document maybe in an RMA situation where patient is refusing to go to the hospital, patient is ANO times 4, meaning the patients completely understand the circumstances, they understood the risks, rather than documenting ANO times 3. Now, if the patient is not fully alert, we can document the patient is responsive to voice, meaning they are not able to recognize their environment. We walk into the room, they don't say anything, they don't recognize us, and maybe we have to shout at them or speak to them until they actually respond. In this case, we use that term responsive to voice. We do not use the term ANO anything. I see very commonly people use the responsive to voice ANO times 1. That means that they're alert. If you use the term A, it means the patient is alert. Don't use the term ANO anything if the patient is not alert. You can use the term responsive to voice times 1, 2, or 3, right? Because if the patient is not really alert of their surroundings, but you have to yell at them, hey, John, what's your name, right? I kind of gave them the name, so don't use that. But in the situation where I have to ask them questions and they're not really responding properly, or maybe they give me 1 or 2, I might be responsive to voice times 1 to name or to person and place. So I want to be able to get them specifically of what might be their specific mental status under responsive to voice. Do not use the term ANO anything if you do not have a patient that is alert. And again, if the patient is responsive to pain, meaning that you need to touch them, you need to pinch them, you need to be able to get their attention for them to be able to respond. So once you touch them and to be able to generate a response, they're considered responsive to pain. You can use that by pinching the skin of their shoulder or the back of their hand. That's able to elicit some kind of painful response. We typically stay away from the sternal rub with a little bit of pinching to their hand or to their shoulder area to be able to generate some kind of response from them. And if they respond to pain, they either grimace, they start talking, they would be considered responsive to pain. However, in the nursing home, you may see the term or hear the term tactile stimuli. Patients responsive to tactile, which is essentially responsive to pain because it requires somebody to touch them before they respond to their environment. And again, you can use the term responsive to pain times 1, times 2, times 3, because I have to shake them awake and I'm moving them and I say, hey, what's your name? They provide their name. They might be responsive to pain times 1 to name. Again, do not use the term ANO. ANO means the patient is alert. or the patient is completely unresponsive, right? If the patient is not alert, not responsive to voice, not responsive to pain, does not make any kind of recognizable movements to our stimulation. And that means that the patient might be fluttering their eyes, patient might be breathing, patient might even be moving their arms or legs unconsciously, but they're not making any conscious movement. So in that case, we're going to consider that patient unresponsive. We want to use the term unconscious on our PCR because even though sometimes the call type might be unconscious, we don't want to necessarily measure brain activity. So we are discerning whether they are responsive to their environment or they're responsive to us. The best way to document that would be simply unresponsive. Keep in mind that the GCS, we document the Glasgow Coma Scale inside the vital section for every time we do a set of vitals. And this kind of correlates a little bit to the mental status, but it delves a little bit deeper. The first one is the most common one, which is essentially what we just spoke about, was spontaneous or eye-opening, which is are they alert. Now, keep in mind that spontaneous eye-opening might have to do physically with their eyes, rather, so a blind person technically cannot have spontaneous eye movement, but again, could be if you are really kind of judging whether they are aware of their surroundings rather than using their physical eyes. They're responsive to sound or to voice, they responded to pressure or touch, or not responding at all to any of those stimulations. Now, in addition to that, we're going to respond whether they're oriented. So if they are alert, are they oriented, confused, words, meaning are they using some kind of words or inappropriate words or simply inappropriate sounds or incomprehensible sounds? So that would be my verbal response. And then motor response, are they obeying commands, meaning they are understanding what's going on, they're able to follow instructions? Are they localizing pain, meaning that they are able to point or to be able to kind of jab towards the pain? So if you ask them a question, you tell them to raise your hand, they don't really respond to that. But if you ask them where the pain is, they may be able to move their arm or gesture towards it. That would be localizing pain. Normal flexion, meaning that they move away from pain. So they don't point to the pain, but they can at least move away from it if you were to touch part of their body that would be painful. Abnormal flexion would be moving away from something in an abnormal way, and the extension, which is definitely a little bit worse, is when you extend towards the pain, which is typically a neurological finding. So the lowest GCS you can have is 3 for unresponsive, and the highest GCS you can have is 15. In which case, if the patient is fully alert and oriented, they should be 15. If they are alert and confused, it might be 14, so maybe 1 less. So establishing the baseline mental status for most of these patients are going to be very helpful, because if you have a patient that is alert and oriented times 3, fantastic, we're going to document that. But if we have an elderly patient that's at home in a nursing home, or patients at home and may suffer from either a dementia or Alzheimer's or some kind of other medical decline, we want to establish what their normal would look like. If we find a patient that is at home and confused, is that normal for the patient, or is that new that started this morning? If it's new that started this morning, I'd be a lot more concerned for that patient I'm treating for altered mental status. If it's baseline, I want to make sure I document that this is normal for the patient. And simply documenting this patient is baseline. If they are baseline at responsive to voice or responsive to pain, if I can figure out how long that's going on for, that would be definitely helpful as well. So if the nurse might tell you, yeah, the patient normally doesn't really talk very much. Well, when did that start? Well, 2 days ago, right? That's a pretty serious change from alert and oriented from 2 days ago. So not only documenting what the patient was doing yesterday, but when did they start declining, or when was the mental status changed based on this?